Is what do you do if they're stuck in a posterior pelvic tilt? So this is where in the Bobath concept we would differentiate between, are they in posterior pelvic tilt through the appropriate muscle activity for posterior pelvic tilt, or are they in a mechanical posterior pelvic tilt because that's just where their body segments are, right? So there's a difference between, is the body segment where it is just because biomechanically that's where it's being taken, or is the body segment where it is because of muscle activity that's acting upon the body segment, right? So many of our patients, for example, spend a lot of time in sitting, yes, and they are in sacral sitting, and then their trunk is flexed on top of them. That is not a posterior pelvic tilt, right? That's a biomechanical posterior pelvic tilt, all right? But if I actually got them to sit on their ischial tuberosities, which is where they should be sitting, are they stable through their upper trunk so that they can select posterior pelvic tilt, which actually is lower abdominals, eccentric lengthening of their lumbar extensors, yes, and concentric proximal hamstrings, so that they can actually grade the loss of their center of mass to come down and then gain the appropriate activation to actually come up into anterior pelvic tilt. So there's a differential motor activity for posterior pelvic tilt in sitting versus posterior pelvic tilt and anterior pelvic tilt in standing, right? In sitting for anterior pelvic tilt, I want stable femurs, so that what I want is my initiator, my prime mover, is my lumbosacral extension, which takes me towards extension, and eccentric lengthening of my proximal hamstrings, which allows my ischial tuberosities to move posteriorly so that I can come towards an anterior pelvic tilt, right?